Most people believe that if a medication helps you lose weight, it must be doing your body a favor. The pounds come off, the clothes fit better, the blood sugar improves, the doctor seems pleased. I used to share that simple framework, until I started reviewing the body composition data of older adults who had been on the new generation of weight loss medications for 6 months, 12 months, 18 months. The scale had moved in the right direction, but underneath that number, something concerning was happening. Not in every patient, not even in most, but often enough and quietly enough that almost no one was talking about it. The fat was leaving, and the muscle was leaving with it. In some cases, in roughly equal measure. In a younger body, that loss can be slowly rebuilt. In a body over 60, that loss is much harder to reverse, and the consequences ripple into everything from balance to bone density to cardiovascular function. Here is what almost no one is telling patients before they start these medications. The way you take Ozempic, Wegovy, Mounjaro, and the other GLP-1-based medications matters enormously after 60. The weight that comes off should be fat. The weight that stays should be muscle, and achieving that outcome requires more than just taking the injection. Today, I am going to walk you through what is actually happening inside the body when these medications are used in older adults, why muscle preservation deserves equal attention to fat loss, and the practical steps that protect strength, function, and independence while still allowing the medication to do what it was designed to do. This is not a video telling anyone to avoid these medications. They are remarkable tools. For the right patient, used in the right way, they can transform metabolic health and quality of life. The message is simply that the conversation around them has been incomplete, and the missing piece matters most for older adults. Let me begin with a basic concept. When the body loses weight, it almost never loses pure fat. Some portion of the lost weight is fat tissue, some portion is water, and some portion is lean tissue, which means muscle. In a younger person who is also strength training and eating adequate protein, the muscle loss can be minimal. In an older person who is simply eating less because the medication has reduced appetite, the muscle loss can be substantial. Research on these medications consistently shows that somewhere between 20 and 40% of the total weight lost is lean tissue rather than fat. For a person who loses 30 pounds, that can mean 6 to 12 pounds of muscle gone. In someone over 60, who already loses muscle naturally each year through a process called sarcopenia, that additional loss can push the body across an important threshold. The threshold where falls become more likely, where stairs become harder, where getting up from a chair takes more effort, where the ability to live independently begins to feel less certain. This matters more than people realize. Muscle is not just about appearance. Muscle is metabolically active tissue that helps regulate blood sugar, supports bone density, drives basal metabolic rate, protects joints, and provides the literal foundation for movement and balance. When muscle declines, blood sugar control often worsens, even after weight loss. When muscle declines, the risk of falls rises sharply, and a single fall in an older adult can trigger a cascade of decline that takes months or years to recover from. When muscle declines, the body becomes less resilient to any future illness, surgery, or stress. This is not theoretical. It is one of the most consistent findings in geriatric medicine. So why does muscle loss happen so readily on these medications? The answer comes down to two interacting factors. The first is appetite. GLP-1 medications work largely by reducing hunger, slowing stomach emptying, and creating a sense of fullness from smaller portions. That is exactly how they produce weight loss. But that same mechanism often leads patients to eat dramatically less, sometimes half of what they were eating before. And the protein in the diet is often the first thing to drop. People feel full. They pick at the meal. They eat the easy carbohydrates and skip the chicken or the fish or the beans. Over weeks and months, the cumulative protein deficit becomes significant. The second factor is activity. Older adults often respond to weight loss by becoming less active, not more. The energy isn't there. The hunger isn't there. The drive to move isn't there. And without resistance training, without the signal to the muscle that it is needed, the body breaks it down for fuel. The combination of low protein intake and low resistance training is a recipe for muscle loss. And it is exactly the combination that often develops on these medications without anyone noticing. Now let me explain what should be happening instead. The framework is simple in concept and powerful in practice. 3 pillars protect muscle during weight loss in older adults: adequate protein, regular resistance training, and medical monitoring. Skip any one of these and muscle loss accelerates. Combine all 3, and the weight that comes off is far more likely to be the right kind of weight. The first pillar is protein. The standard dietary recommendation for protein has been roughly 0.8 grams per kilogram of body weight per day. But that recommendation was based on younger adults and on preventing deficiency, not on optimizing health. For older adults, particularly those losing weight, the research increasingly supports a higher target, often in the range of 1.2 to 1.6 grams per kilogram of body weight per day. For a 150-pound person, that translates to roughly 80 to 110 grams of protein daily, distributed across meals. The distribution matters. The body uses protein most efficiently when it arrives in moderate doses several times throughout the day, rather than concentrated in a single large meal. Roughly 25 to 30 grams of high-quality protein at each main meal is a reasonable target, with additional protein in snacks if appetite allows. What does that look like on a plate? A palm-sized portion of chicken, fish, lean beef, or tofu typically delivers around 25 grams of protein. 3 eggs deliver about 18 grams. A cup of Greek yogurt delivers 15 to 20. A scoop of whey or plant-based protein powder mixed into a drink delivers 20 to 30. The challenge on appetite-suppressing medications is fitting that protein in despite reduced hunger. The strategy that works for many patients is to eat protein first at every meal, before vegetables, before grains, before anything else. If the meal ends early because of fullness, at least the protein has already been consumed. Protein supplements in the form of shakes or bars also become more useful in this context, not as a replacement for whole food, but as insurance when appetite is unreliable. The second pillar is resistance training. This is the single most powerful intervention against medication-associated muscle loss in older adults, and it is the one most often overlooked. Resistance training does not require a gym. It does not require heavy weights. It does not require complex programs. It requires consistent, progressive loading of the major muscle groups, 2 to 3 times per week. Body weight exercises such as sit to stand from a chair, wall push-ups, and step-ups can be remarkably effective starting points. Resistance bands offer a low-cost, joint-friendly way to add load. Light dumbbells, used in patterns that target the legs, hips, back, shoulders, and arms, build strength meaningfully, even at modest weights. The key is that the muscles must be challenged enough that the last few repetitions feel difficult. Without that challenge, the body has no reason to maintain the muscle it has, much less build more. The recommendation for older adults on weight loss medications is to begin resistance training before or alongside the start of medication, not months afterward. Starting from a position of strength and continuing to train through the weight loss period is far more effective than trying to rebuild muscle that has already been lost. If joining a gym feels intimidating, working with a qualified trainer for even a few sessions to learn safe form can make all the difference. Many community centers, senior centers, and physical therapy clinics offer programs designed specifically for older adults. often at modest cost or covered by insurance. The third pillar is medical monitoring. This means more than checking the number on the scale. A thoughtful approach to weight loss medication in older adults includes periodic assessment of body composition, where possible, using methods such as bioelectrical impedance analysis or DEXA scanning that can estimate the proportion of weight loss coming from fat versus lean tissue. It includes attention to grip strength, which is one of the simplest and most predictive measures of overall muscle health. It includes monitoring of nutritional intake, sometimes through a brief food log, to confirm that protein and overall calories are not falling too low. And it includes attention to functional measures, such as how easily a person can rise from a chair, how steady balance feels, how confident walking remains. These measures, together, paint a far richer picture than weight alone. There is one more clinical concern worth raising specifically for older adults: bone density. The same loss of mechanical loading and reduced nutrition that drives muscle loss can also accelerate bone loss, particularly in older women, but also in older men. Adequate protein, adequate calcium and vitamin D, and weight-bearing exercise all support bone health. For patients on weight loss medications who have existing osteoporosis or osteopenia, periodic bone density testing and an explicit bone protection plan are reasonable parts of comprehensive care. Losing weight without protecting bone is a trade-off that can have consequences for years to come. Let me address a question that comes up often. Should older adults take these medications at all? The honest answer is that it depends entirely on the individual situation. For an older adult with type 2 diabetes that is poorly controlled despite other medications, with significant obesity-related health problems such as severe sleep apnea or joint disease, and with a thoughtful plan for protein and exercise, these medications can offer meaningful benefit. The metabolic improvements, the reduction in cardiovascular risk factors, and the improvement in mobility from losing excess weight can be genuinely transformative. For an older adult who is mildly overweight, who is already losing some muscle naturally, who is not currently strength training, and who does not have a clear plan for protein intake, the equation is different. The medication can produce weight loss, yes, but the kind of weight loss it produces in that context may not actually improve overall health and function. The decision deserves a careful, individualized conversation with a doctor who understands both the metabolic benefits and the muscle preservation challenges. Let me share a story that illustrates these principles. A woman in her late 60s came for follow-up about a year into treatment with a GLP-1 medication. She had lost 32 pounds, which on the surface looked like a tremendous success. Her blood sugar had improved. Her blood pressure was better. She was thrilled. But during the visit, she mentioned in passing that she had fallen twice in the previous 3 months, something that had never happened before. She also mentioned that climbing stairs left her short of breath in a way it had not previously, and that she had stopped going on her morning walks because she felt unsteady. When we tested her grip strength and her sit-to-stand performance, both had declined meaningfully from her baseline a year earlier. Her body had lost weight, but a substantial portion of that weight had come from muscle, not fat. The plan we developed was straightforward. Her medication dose was not changed initially, but her protein intake was deliberately increased. She began working with a physical therapist on a structured resistance program twice a week, and her food logs showed that her overall calorie intake had been so low that even her protein intake had been inadequate. Over the following 6 months, her weight stabilized, her grip strength improved, her balance steadied, and her walks resumed. She had not needed to choose between metabolic health and physical function. She had needed a more complete approach. Her story is far more common than the public conversation about these medications suggests. The marketing focuses on the weight that comes off. The clinical reality includes what comes off with it and what gets left behind. For older adults in particular, that distinction shapes outcomes for years. Let me offer 4 practical questions worth raising with your doctor if you are considering one of these medications or are already on one. The first question: given my age, my current muscle mass, and my activity level, what is your specific plan for protecting muscle while we work on weight? An answer that focuses only on the medication and not on protein, training, and monitoring is incomplete. The second question: how will we measure progress beyond just the scale? Body composition assessment, grip strength, functional measures, and nutritional review all belong in the picture. The third question: what is the protein target you recommend for me, and how will we ensure I am hitting it? Generic advice to eat more protein is not enough. Specific grams per day, distributed across meals, with practical strategies for appetite-suppressed eating, is the appropriate level of detail. The fourth question: what resistance training program do you recommend, and what referrals can you provide? A doctor who is invested in your overall outcome, not just your weight, will have an answer ready. There is one more important point I want to make explicit. These medications are not designed to be lifelong solutions for everyone. The current evidence suggests that when they are stopped, much of the lost weight tends to return over time, often along with continued muscle loss during the regain. This is one reason why the muscle preservation work matters so much during the medication period. Building a strong foundation of habits around protein, resistance training, and overall activity provides protection regardless of what happens with the medication later. If the medication is continued, the habits make the weight loss healthier. If the medication is stopped, the habits give the body a much better chance of maintaining function and metabolic health going forward. There is also a practical consideration around the rate of weight loss itself. Faster is not always better. When weight comes off very rapidly, particularly more than 1 to 2 pounds per week sustained over months, the proportion of muscle in that loss tends to increase. The body, in essence, does not have time to adapt and protect its lean tissue when the calorie deficit is too steep. For older adults, a slower, steadier pace of weight loss often produces better long-term results, even if the early numbers on the scale move less dramatically. This is one reason that some clinicians now recommend lower starting doses of these medications in older patients, with slower titration, allowing the body to adjust and the muscle preservation strategies to take hold. If your weight loss feels rapid and your appetite has dropped to almost nothing, that pattern deserves a conversation with your prescriber about whether a dose adjustment makes sense. Hydration also deserves a brief mention because it is so often overlooked. These medications slow stomach emptying and reduce the sensation of thirst along with hunger. Many older adults on these medications drink less water than they need without realizing it, and dehydration in older adults can produce dizziness, falls, kidney strain, and constipation. A simple practice of drinking water on a schedule rather than waiting for thirst can prevent a substantial number of avoidable problems. Constipation in particular is a common side effect of these medications, and adequate fluid intake combined with adequate fiber is one of the most reliable ways to manage it without additional medications. Let me close with the broader point that frames everything else. The goal of treatment in older adults is not to look thinner. The goal is to live better, with more strength, more independence, more mobility, and more years of doing the things that make life worth living. Weight loss can serve that goal beautifully when the weight that comes off is fat and the muscle that powers life is preserved. Weight loss can undermine that goal when the muscle goes with the fat and the body is left lighter but less functional. The difference between those two outcomes is not luck. It is a plan, applied consistently, with attention to the specific physiology of the older body. If you or a loved one is considering one of these medications, or has already started, the conversation worth having is not whether to take them. The conversation is how to take them in a way that produces the right kind of weight loss for the right kind of long-term outcome. Ask the questions. Make the plan. Build the habits. The medication is a tool. The plan around it is what determines whether the tool builds a better body or quietly subtracts from the one you have. Everything shared today is general medical information based on published endocrinology, geriatrics, and metabolic research. Every individual's situation is different, and decisions about medication, diet, and exercise should always be made in partnership with your own doctor, who knows your full medical history. Never start, stop, or adjust any medication on your own. The information in this video is intended to support better conversations, not to replace them. Take care of yourself, protect your strength, and give your body the kind of attention that allows it to carry you well through every decade ahead.